Yes, pustular psoriasis slide, okay? I mean, derm is not that hard, okay? This is important stuff, all right? So we're gonna do ocular ultrasound first, and then we're going to take a quick break, get through the DVT ultrasound lecture, so you have a basis, and then from there, we're gonna actually practice today. Second half of the lab is practice. Everybody doing okay? Practice last week went well? Yeah? Okay. Kagan Williams might join us. So visual echoes, ocular ultrasound. So off the top of your mind and heads, what are some good indications for an ocular ultrasound? So patient says, I have sudden vision loss. That's a really good one. I heard TBI. Why would an ocular ultrasound be good for a traumatic brain injury? Increased intracranial pressure. Can we determine that by just doing an ocular ultrasound? The truth is, yes, we can actually measure the optic sheath nerve diameter, which is pretty cool, which is a direct correlation to intracranial pressure. What's a normal intracranial pressure in the brain? Less than 21. Okay, good. What about ocular pressure? Same, less than 21. Okay, so it correlates with the optic sheath nerve diameter. What are some other indications for ocular ultrasound? Somebody said vision loss. What kind of things cause sudden vision loss? Retinal detachment. Yeah, trauma. Okay, foreign body, dislocated lens, globe rupture. What else? Okay, we can actually. What's a condition that causes papilledema that's not related to a brain injury? Pseudotumor cerebri. So can I measure a young female's optic sheath nerve diameter and determine if she has pseudotumor? The answer is yes. So here's a bunch of indications. So foreign body, those welders that come in that have been welding their whole life, they don't wear any kind of eye probe, a little piece of metal or wood, we can see all of that. What are some other causes of sudden painless vision loss? Those are buzzwords. They ask you this on the pins. CRAO, CRVO, good. And then of course you said retinal detachment. Okay, good. So the take-home points is that this is really easy, all right? It's just going to take a little bit of dexterity to work with the ultrasound machine. It's kind of reproducible. It doesn't expose the patient to any kind of radiation. The keys here is you have to stabilize your hand, and we're going to use a ton of gel. We're going to create like a big gel pillow. Because if somebody has like a globe rupture or an eye injury, the last thing you want to do is put even the weight of the probe, and especially you pushing down or anything onto the patient, okay? We're going to check ICP, and remember the term 3x5. All right, that's going to come into play. You actually have to use your calipers in the ultrasound machine. You're going to drop a set of calipers 3 millimeters posterior to the eye, so you can get right in the middle of the optic sheath nerve, and then you're going to go wide, and it should not be more than 5 millimeters wide. That might sound overwhelming to you, but it's going to be really easy once we start practicing, all right? So remember, 3x5, lots of gel, and then we do static versus dynamic evaluation. What do you think that means? Motion, not motion, right? A clear picture where the patients, even though their eyes are closed, are looking straight ahead, so you can actually see the anatomy. And then we do a dynamic exam. The patient looks left, right, in the transverse view, or up, down, in the sagittal view. Okay, so it's going to make more sense after we start actually looking at some good pictures, all right? All right, indications. We already talked about this. Sudden vision loss, eye pain, ocular trauma, foreign body, and then to elevate intracranial pressure, or pseudotumor, right? It could be from traumatic brain injury or pseudotumor cerebri. Okay, so contraindications technically is a globe rupture. Why would that be? Yeah, because we just really don't want to put any pressure whatsoever on the eye. Some advanced ultrasonographers, like Mr. Williams in the back, Captain Williams, we know how to do it really carefully without putting any pressure. But if you put any pressure at all on a globe rupture, it's going to actually precipitate worsening of the globe rupture. All right, so I've seen several globe ruptures in my days. It's usually the same situation. No kidding, there I was, just minding my own business. These people jump me. And their eyes are so swollen, you can't even pry the lids apart to actually look at the globe. So sometimes, this is helpful where we put the probe on very gently, not knowing what's underneath because we can't even see. And so then we'll see the characteristic globe rupture where the vitreous has completely lost its form, which is like a blob of junk. And we're like, okay, this is a globe rupture. And you can actually see that through the lid. without trying to, you know, traumatize the eye by prying it apart. Has anybody seen a really major eye swelling, like where you can't pry the eyelids apart? No? Okay, it happens, okay, quite a bit. All right, advantages, easy to perform at bedside, it's portable, it's non-invasive, no radiation. Disadvantages are really the contraindication is the glow rupture, but the disadvantages are you actually have to practice and do this. Get some reps in, that way you can get your caliper measurements. The more you do it, the better you're going to be at it. All right, so what are some of our clinical questions? I just told you some of the indications why we would want to do an ultrasound of the eye. What kind of clinical questions are we asking ourselves? Why are we doing this point of care ultrasound? What's that? Yeah. Is there a widening of the optic nerve sheath to basically tell us, is there increased intracranial pressure? What are some other clinical questions? We talked about all these indications. It's the same thing as indications, but you know, when we do point of care ultrasound, we're asking a clinical question that we're going to answer for ourselves to make a decision about our patient care based on the answer to that question. So our question is, depending on the setting, if it's trauma, is there glow rupture? Is there a lens dislocation? Is there increased intracranial pressure? If it's a sudden vision loss, is there a vitreous detachment, a retinal detachment, a vitreous hemorrhage? What do those people present with when they have a vitreous detachment or hemorrhage? Floaters, good. Okay, good. Is there a foreign body and is the lens dislocated? Okay, so here's this little cheat sheet that I put in your presentation. This is just to remind you of some of the causes of sudden vision loss, painless vision loss, versus traumatic vision loss. And that's two broad categories that make sense just based on the patient's history, right? And so this kind of gives you just a cheat sheet to refer back to, and I'm going to teach you all this right now, and then we're going to refer back to this, and I actually have it at the end of the presentation as well. Okay, so how do we prepare? What do you think we need? We need a patient, very good, right? We need lots of gel, all right? What else do we need? We need an ultrasound machine, right? And which probe do you think that we need for this particular? A superficial one, which is linear, very good. And there's actually an optic or an ocular preset, which is really good. So that helps us out. So you need a set of gloves. You can put gel directly around the orbit of the eye with your eyes closed. The gel is a water-based gel. It does burn a little bit depending on which kind. You can actually put a Tegaderm over the eye, but also be careful not to put it over the eyebrows. I don't want to see a bunch of eyebrowless students. I like to see your mad faces, and I might get confused if I don't see the eyebrows looking mad, okay? Also, my partner in the back there, as a lot of guys might find interest in FLARP. Does anybody know what FLARP is?
Yep. It's the Nickelodeon thing.
It's the only guys that seem to have an interest in it. What does FLARP do?
It's like it makes sounds.
It makes what kind of sounds?
Very, very interesting fart.
No, yeah, fart sounds, okay? It's a flatulent FLARP. Okay, it's like a putty, like in my days it was like silly putty. But anyway, FLARP is a substance that he studied that you can actually put over the eye as well that doesn't remove the eyebrows or eyelashes off of a patient. You can actually ultrasound through it. So I'll let him tell you all about that. But anyway, most of us just use regular gel because that's what we have at our disposal, but some people carry FLARP. Okay, if you just happen to carry it because it's funny and it makes little stupid noises, you can actually use it on the patient's eye as well. You did a study, right? It's really good stuff. Go ahead and tell them about it.
So, alright, FLARP is a manual pre-hospital austere ultrasound, one of the alternative means that you can use FLARP. I don't like when I get ultrasound gel in my eye because it's stinging.
It does burn a little bit. I'm sorry, it does burn just a little bit, but
Not a lot. Like if you want, you can put ultrasound gel in my eye and I'll survive. So I decided we were going to do a study comparing basically a non-inferiority trial comparing FLARP to ultrasound gel for ocular images. And currently we need one more reviewer because our inter-rater reliability was a little messed up. Alright, so when you build a study, it's important to factor in like inter-rater reliability. And I chose to use the American College of Emergency Physicians ultrasound grading rubric of 1 through 5, where anything above 3 is an acceptable image, just better, you know, like 3 is acceptable but could improve, 4 is pretty good, like 5 is textbook. 1 and 2 are not good. And with that, with only 3 reviewers, you end up having inter-rater reliability because anything above 3 is still okay, but people will do like a 3 on 4 or a 3 on 5, and those are now not related. So I need more people to use my ads.
So, but in his experience though, it's been a decent image, right?
Yeah,
We're gonna
everyone,
see it.
all
Okay.
the reviewers that I've spoken to, because you very quickly can tell the difference, think that when you get a good image of with Flark, it's as good, if not better than the ultrasound gel. But the problem is that people play with it and make the fart sounds, there's a lot of error introduced into the medium, and then that obviously affects.
Okay.
It's good.
So it's nice to have an alternative that where we don't remove people's eyelashes or eyebrows. The gel does burn a little bit. I haven't heard a lot of people complain. Some people who have like really dry eyes, they may be a little more prone to burning a little bit, but it's a water-based gel. Okay, so it hurts like a tiny bit, like not even a 1 on a scale of 1 to 10. Okay, but some people are more sensitive, right? Just like other people's pain tolerance are a little different. Anyway, so we use a lot of gel is what we're going to use. If you really want to use Tegaderms, we do have some. Just be really careful. And like the Flark that can get air, Tegaderm can get air underneath it. So when you put it on and it's not completely flat, and that air will obscure your ultrasound images just like bowel gas would if we're doing an intra-abdominal ultrasound. All right, so we're going to use an ocular preset of a linear probe, and we're going to do it in 2 views. We're going to do it in a sagittal and a transverse. So this view is sagittal, and this is transverse. Okay, so if the probe marker is to the patient's right, that's a transverse view of the eye. If the probe marker is towards the patient's head, that's the sagittal, okay, or short view, long view, okay, but we're gonna go through that. I know it sounds confusing, but it's gonna be perfect once you guys put your hands on. Did you guys feel like you got a lot of hands-on and some reps with the EFAST? I feel like it was pretty easy, right, mostly? Some people need some more reps, that's okay, we have more time to practice, but in general, you're kind of getting the gist of it, right? Yes, most people? Okay, so what do we see? So I put a bunch of gel on a patient, and if I'm doing this because I want to check optic sheath nerve diameter, where should my patient be positioned? It's completely supine? Completely upright? How should the patient be positioned if we suspect TBI? Supine? 30 to 45 degree angle at a minimum, right? And the reason for that is that we're going to decrease intracranial pressure. Just by having the patient's head elevated 15 to 30 degrees, you can actually reduce the intracranial pressure by 15 millimeters of mercury because you're allowing gravity to help drain the CSF. All right, so not supine, but guess what? These things don't really elevate. So in our case here, except for the beds in the back, we're going to have the patient completely laying on their back. If you have the patient completely upright, the gel can't stay there, it's just going to fall down their face. All right, so at a minimum, if there's no interocular injury or traumatic brain injury, and you're looking at it for other reasons like foreign body or whatever, then they could theoretically be supine. If we're measuring the optic sheath nerve diameter, just remember your patient should be at a 30 to 45 degree angle. And this is what you see. So they got a big gel pillow on top of the patient's eye. They're bracing the probe. This is more important now than ever to brace the probe. In other words, I'm going to hold the probe with my thumb, index, and middle fingers, and then I'm going to use my pinky and ring fingers to support the probe, so I'm not pushing on the gel at all. In fact, if you do push the gel, it's just going to disperse it all over and it's going to mess up your image. So I'm going to anchor myself on the patient's bridge of their nose, forehead, or their cheekbone, depending on their anatomy. Some people have really big, Cro-Magnon type foreheads, so you can't really brace on them, okay? Some people have little tiny faces, so you have to like use their cheek, whatever. Just based on the anatomy, make sure you anchor yourself. And so what do we see here? What does this look like? It looks like an eyeball. Go figure. Okay, so what do we see right up here at the very top? What's that very top tissue looking structure? Yeah, it's labeled. It says eyelid, right? And so what's right behind the eyelid? The anterior chamber. What's comprised of the anterior chamber? Yeah, the pupil cornea, very good. I know it's been a while since you had a hint. All right, here you can actually see the iris, believe it or not, right there, the ciliary muscles in the iris. Right behind the iris, this little hyperechoic structure is the lens, and so that's why you can see it so clearly if the lens is dislocated. This little hyperechoic structure will be way down here somewhere or off to the side. And then we can actually see just behind that is the posterior chamber, and behind that is the vitreous body. Also, some people refer to it as the vitreous chamber. So that's all that black stuff, and it's filled with fluid vitreous kind of a substance, so that's why it looks black. Back here, the retina, it goes all the way around. So the retina is attached all the way around, circumferentially around the eye, but it attaches in two places, and this is one of them at the back. So when we drop those calipers, 3 down, 5 across, we're measuring the shadow here, which is a representation of the optic sheath of the optic nerve, and that's what we're measuring, inner wall to inner wall. Does that make sense? And how wide should it be? When I said 3 by 5, we're going 3 down, just so that we don't get that posterior acoustic enhancement that we talked about before. Remember when we ultrasounded the bladder, the posterior wall looks super white? Well, the same thing happens in the eye because it's vitreous or fluid filled, and so that back of the retina looks super white. So we want to drop our calipers down 3 millimeters. That way we know we're getting beyond that enhancement, and we're actually capturing the optic sheath nerve. We're going to measure inner wall to inner wall, and it should be less than, what did I say? 5. That's 5 millimeters. So if your screen says centimeters, it's going to say 0.5. All right? Did you have a question in the back, ma'am?
No, you answered it now.
Okay, so we're going to go through this a little more carefully. So this is a anatomy normal eye exam. Again, anterior chamber, we got the lid up here, anterior chamber, we got iris, we got lens, we got the vitreous body, and then back here's the optic sheath nerve. And we're going to drop our calipers 3 down and then measure across. Should be less than 5. And an adult, it technically can get up to 0.57 centimeters or 5.7 millimeters. Anything above that is definitely an increase in a cranial pressure. In children, it's 4.5. All right, millimeters. All right, you with me? All right, it's fun stuff. Now here's a dynamic exam. So right away, you put the probe on, you see all that anatomy, you center yourself, you're anchored, and now you're going to say, okay, patient, in this transverse view, so the probe markers to the patient's right, you're going to have the patient look left, right, left, right. And we're looking for specific things. If we're having the patient look left, right, we're looking for anything that's back here. They should not have any soot in the back of the eye, right? No, should not have any something up in theirs in the back of the eye. So if they have like a vitreous detachment or a bleed, you're going to see stuff rumbling around back there. Or a retinal detachment, it's going to be rumbling around back there, and I'm going to show you how that looks. So that's a dynamic exam in the transverse view. But we look in 2 views. So you also can measure in this transverse view the optic sheath nerve diameter. In real life, we measure in both views. Then you're going to put the probe marker towards the patient's head, do the same thing. Now you're going to have them look up, down, up, down. That's the dynamic exam. Up, down, left, right. Make sense? All right. So again, step by step. Step 1, we got our patient, we got the head of the bed elevated 30 to 45 degrees. We're doing a giant gel pillow. So I know that you guys have been using a lot of gel when we do the EFAST, but we're talking like a couple centimeter of gel pillows, just like up really thick, all right? And that way we don't have to put any pressure at all on the probe or the eye. We're going to select the linear probe. We're going to anchor wherever we have to on the patient's body and head, nose, or cheek. In this picture, they're actually anchoring right here on her temple. All right, depends on the size of the probe and stuff, but it should be a linear. So step 2, so step 1, it just said anchor, and then step 2, it says transverse static, then the dynamic exam. All right. Step 3, we're going to rotate the probe 90 degrees, look at it in the sagittal view. So this is where the probe marker is towards the patient's head. Now they're going to look up, down, up, down. Make sense? All right. And then step 4, we're going to go back to the transverse view. That's actually the best view to measure. And for your test out purposes, you only have to measure in one view, just for time purposes. There's so many of you, so few machines, so few instructors, so just measure it in the transverse view if you can see it. And so sometimes you have to rock the probe about 15 degrees or kind of go a little bit lateral in order to see the shadowing of the optic sheath. And then you're going to freeze the image once you get a good vision or view of that shadow. You're going to drop your first set of calipers at the back of the posterior eye here, right at where the retina is. You're going to drop it down and go just do a straight line to where your little centimeter marker is saying 0.3 centimeters or 3 millimeters. All right? And you're going to leave those calipers alone and just leave them there. Then you're going to drop a second set of measuring calipers and go even with that point that you just dropped, and then measure inner wall to inner wall. It should be less than 5. Now, some folks of different descents just naturally have a little bit wider optic sheath nerves diameter. Some people are like closer to 5, 5.5. In the correct setting, this could indicate a TBI, but for y'all, you know, it's obviously, nobody's just sitting around with increased intracranial pressure or interocular pressure unless you have pseudotumor or something, okay? So, in real life, we'll measure it in 2 views, and then we'll also compare it to the other eye. So, all right, here we go. Optic sheath nerve. So, again, we usually measure this in the transverse view. We can tilt the probe, however, like 15 degrees or so, so we can actually see that shadowing. We're measuring inner wall to inner wall, 3 by 5 is what I want you to remember. Again, this is the optic nerve, this is the shadowing, and that's what we're trying to measure. Everybody can see that pretty good? Sometimes it's hard to get, so if you need help, just ask us, because we're going to do some practicing here. So again, we're going to drop our calipers. It doesn't have to be perfectly straight to the back of the eye. Sometimes we're off and canted a little bit, so just make sure you cant your your calipers appropriately. So they're going 3 down, should be less than 5 across. All right, again, on this side, 3 down, 5 across. Anybody completely lost? Yeah, that's actually an ultrasound function where you're going to freeze the image of the eye once you get a good view of the shadow. And honestly, these nice machines and even the older ones, the mouse pad, like if you kind of captured it but then you accidentally moved past it, you can freeze the image and then use the mouse pad to kind of go back a few seconds in time to where you saw the shadow, which is helpful. And then this is all frozen now, so your hand and everything is off the patient, so now you're working the machine. And there's actually a button that says calipers or measure, and you're going to hit it and it's going to drop 2 little X's, and with the mouse pad you're going to adjust these X's to go to the back of the eye, drop them down 3, and then you're going to measure across, and it should be less than 5 millimeters. I'm going to show you, so it's just hands-on, but it's an ultrasound machine function where you're going to be touching buttons that say calipers, which are measuring devices. Kind of like when you look at a CT image, you want to measure the size of the appendiculus and the appendix. You can drop little measurement calipers onto your CT image and measure. Yeah?
Is there a measurement, like a minimum threshold for the optic sheath?
I don't know. I don't think so. There should be one there, unless they've been enucleated or something, right? But no, I don't know of any minimums. We're mostly worried about increased pressure. Okay. So here's an example of an increased optic sheath nerve diameter. So they drop the calipers from the posterior wall down 3 millimeters, and when they measured inner wall to inner wall, and that's a little fuzzy, they measured it at 0.68. So anything above 0.57 in adults is technically increased pressure that correlates with an intracranial pressure of greater than 21, so that's increased. That's the right eye. That's nice that they labeled that. Okay, let's look at retinal detachment. So a retina is attached all circumferentially. It's really attached at 2 points, but it surrounds the posterior eye completely. We all agree? It's like it wraps around the vitreous. So when we see a retinal detachment, it's because there's been blood supply cut off from the rods and cones, and it can cause permanent vision loss. You remember from HENT and ocular, what do they present with when they have a retinal detachment? What are they complaining of? The curtain coming down. What's something that might happen right before that? Scotomas, flashing lights, that kind of thing. And it's usually like, hey, I was in a movie theater, I just watched a movie, and I came out and I saw flashing lights and a curtain coming down, sudden vision loss, painless vision loss. So there's a thick hyperechoic membrane that kind of surrounds the entire posterior eye, and we can see that, and that's the retina, but it's tethered back here at the optic nerve. So when it's detached just by ultrasound, we suspect it by history, but when we look at the ultrasound, we're doing that dynamic exam. It almost looks like a Dracula with their cape, you know, he's like flowing it around left and right, and it's always tethered to the back. It may be a bad example. I'm going to show you some videos here. So can you see that little flap? It flaps around, but it's tethered towards the back. And that's important to know because that's what distinguishes a retinal detachment from a vitreous detachment. Because when they're going left, right, it looks like it's just staying on one side of the eye because it's tethered. Okay, even a complete retinal detachment is going to do it from both sides. But you can see here this flap, but it's tethered. So when they're looking left, right, it doesn't cross midline. Same here. Yeah, this is like a complete one, so it's on both sides, but it's still tethered back here at the optic nerve. Do y'all appreciate that? So it's really easy. I love doing this because now when I call opto, I'm like, hey, presented with XYZ symptoms, bedside ultrasound shows a retinal detachment. Like you already know. Pretty good stuff. Vitreous detachment, what do those folks present with? Do they have sudden complete vision loss? No, they usually present with what? We talked about it, floaters, right? They see little specks or floaters, right? And a lot of us, as we age, will start getting some little vitreous hemorrhages or detachments. So the difference is, it's not tethered to the back of the eye like the retina is. So when you have that patient doing their dynamic exam, look left, look right, it looks like one of those old dryers or a front load dryer with clothes just tumbling around the dryer, just keeps going around and around. That's what it looks like when they're doing their dynamic exam. And so you see a bunch of stuff back there, you're like, and you can actually see this is like layered blood, okay? Some hyperacobia, this is layered blood. So this is the vitreous actually separated from the retina, and it remains intact, and you get this hyperechoic membrane. So I'm gonna show you some videos. So unlike the retina, it's not tethered, it kind of just floats around all over the place. Can you appreciate that? Does it look like that to you? Maybe, just take my word for it, okay? All right, so here's some comparisons, how to differentiate retinal versus vitreous. And sometimes it's not super clear, right? If somebody, maybe they have other things going on, and so you can always just know that one of it or the other, but they need an ophthalmology consult anyhow, right? Not optometry, but they need ophthalmology. And here's a comparison chart showing some of the major differences between the two exams. Now, what's the difference between a vitreous detachment versus vitreous hemorrhage?
One the entire thing.
Yeah, so it's a little more focal, or it's just blood. So this extravasated blood kind of accumulates in the vitreous humor of the eye. And so, again, this is that washing machine. It's a little more obvious than this guy. Okay, this is just a vitreous detachment, where it's detached versus here. Let me go through. Here's a vitreous hemorrhage. All right, just see all kinds of hyperechoic material in the back, and it's just kind of floating around all over the place, tumbling around like a clothes dryer, because it's not tethered to the back like the retina. Okay, so they're very similar to the vitreous detachment. All right, so in summary, this is what we're doing. Linear transducer, we're going to measure in two planes. That's the sagittal and transverse. We're going to make sure we measure our optic sheath nerve diameter, usually in the transverse view. In real life, we do it in both views. And remember, 3 by 5. Drop your calipers 3 down, shouldn't be more than 5 across. And what was it in children? 4.5. Okay, very good. Any questions about that? That seems pretty straightforward, right? Except for the caliper piece, which will get our dexterity down. All right, let's just take a quick 5-minute break, just a quick one, and then I'm going to do DVT lecture, and then we're going to have class time to practice it. No idea. That took a little bit. So let's go on to DVT, ultrasound. You guys have seen this a little bit already. How can we detect the DVT in the lower extremities? Yeah, we do venous compression, right? And specifically, which vein are we looking at? So the common femoral vein. And what dumps into the common femoral vein? The saphenous. Now, technically, the saphenous is a superficial vessel, but because it's dumping into the deep system, we have to capture that. So we're going to go through this a little bit. All right, so indications is we're concerned for a DVT, right? The patient might present with leg pain, redness, swelling. What else? What might the patient present with? History or physical exam wise? Maybe they had a recent surgery, right? That's an indication they may have a DVT. Or what else? Yeah, maybe they just recently started estrogen, specifically our OCPs, and smoking, and they just came from a flight from Malaysia, and unfortunately they broke their hip while they were there, and she just found out she was pregnant, even though she's smoking on OCPs. Okay, that can happen. Okay, so if a patient presents like that or suspicion is high, Holman sign is always something that's a buzzword in your exams, but Holman sign has no sensitivity or specificity for a DVT. What does a DVT often look like that we have a hard time distinguishing it from? We just learned this in block 2. Cellulitis, infection. Okay, good. You guys nailed it. So concern for PE. Now, remember, we don't have to CT angio everybody's chest just because they have a DVT, but if they come in with chest pain, tachycardia, pleuritic chest pain, dyspnea with clear lungs, we do ultrasound their extremities looking for where that clot came from. But the opposite isn't true. We don't CT angio everybody's chest unless they have symptoms of a PE, right? This is stuff you guys know. So, what's the disadvantage? Now theoretically, if you're mashing down and compressing right over a clot, there's a theoretical risk of dislodging a small portion of that clot. I personally have never seen it, but this is a quick bedside thing that we can do, and it's gonna help you in a downrange or pre-hospital environment to make decisions on whether this is cellulitis versus I see a clot and I need to evacuate this patient, so they can be on anticoagulation, all right? So this is why we teach it. So that's a theoretical, that's actually clot, and that's where they're compressing over the clot. All right, so what's our clinical question? Are their findings consistent with a DVT? All right, and so I'm gonna see if this thing actually works now. Nope. This thing is driving me nuts. So it's supposed to highlight, yeah, I don't know, man. So our clinical question is there a DVT, right? And we can actually see it, and so that's gonna be pretty fantastic. All right, so what other clinical questions are we asking? This thing hates me today, okay? It's personal. All right, Yep.
Why is it important, this might be dumb, but why is it important to find the DVT if you have PD if it doesn't really change like how you're treating?
we just wanna know where it comes from, so usually we'll do ultrasound of the extremities, lower and then upper, just to see. But you're right, I mean, it's not gonna change the management of that patient, as far as, direct oral anticoagulation, things like that, but it's just nice to know. So incidence, why is it important? Well, we see quite a bit of patients that present with DVTs, right? And most of them are in the lower extremities, which is why we're focusing on the lower extremity DVT ultrasound. But we do and can do bedside upper extremity ultrasounds as well. Clinical signs of DVT is leg swelling and tenderness, and only about 20% of those that we think have a DVT are actually positive. All right, so pretty low. And then a lot of current algorithms use your suspicion, remember your gestalt, your clinical suspicion plus a D-dimer. And remember, we do both when we suspect a DVT, and why is that? Why do we do a D-dimer and an ultrasound? When in 5 minutes I can get an ultrasound and already tell you it's not a DVT, but why do I still want that D-dimer that's gonna take an hour to get back? Because the D-dimer is gonna capture that small percentage of people that have a clot below the knee. Because remember, we only scan from the popliteal fossa up into the groin. All right, so that's why we do both. So advantages, again, rapid, portable, no radiation to the patient, and reveals most significant, clinically significant DVTs. All right, you just have to have your hands on a machine and practice a little bit. It's pretty awesome. Okay, so how do we prepare? What are some things we need in order to do a DVT ultrasound? We need a patient. Very good. You're on top of it.
No hands on.
Okay, I would say that they have to have their anatomy exposed so we can get in there and look at their common femoral vein. So we're going to get way up in the inguinal canal, or just distal to the inguinal canal, in order to see the saphenous vein spilling into the common femoral vein. So we need to see 4 structures: the saphenous spilling into the common femoral vein, superficial and deep femoral arteries. And that's the whole Mickey Mouse looking face complex with the little exclamation mark. All right, and lots of gel, all right? So this time we can have the patient in a supine position. We typically have them frog leg at the bedside, so not if they're too bent, it's too much. If they're too straight, so just kind of frog legged and kind of externally rotated. And we're gonna get way up here into the inguinal canal. And so we're gonna use our linear probe, because that's our superficial parts probe. Some folks have bigger thighs, whether it be muscle or adipose, and sometimes we'll have to actually go to the curvilinear deeper probe. But by selecting the linear probe, it presets to a depth of around 3 to 5 centimeters, all right? And we're gonna have to just adjust. We're gonna use a Venus preset, which is on the actual machine, and again, curvilinear if they have a bigger thigh. So what we're gonna teach is a 3-point ultrasound, which is different than what I learned when I went through. When I learned and went through, I had to identify those proximal structures. Then every couple centimeters I'm compressing. So you compress, go down, compress, 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 until that vein dives down deeper and you can no longer see it, and then I would do the popliteal. Now they're saying, if you just do a 3-point ultrasound, you're gonna catch most, like 90% of the DVT. So they do proximal, mid, and popliteal. That's your 3-point, and I gave you a little cheat sheet in your presentation. So proximal is way up here by the inguinal canal area where the common femoral vein is deep, it's the deep femoral vein, it becomes there, but that's where the saphenous is filling in. Then we'll do kind of a mid, and the midpoint is really not mid-thigh, it's mid-vessel. So the vessel actually dives down about halfway through the thigh, so you're gonna do a proximal and a mid, it's just gonna be a few centimeters distal to that, and I'll demonstrate all of this. And then the popliteal is your third. So we wanna get that saphenofemoral junction approximately, then the bifurcation of the common femoral vein is what you should see, and then lastly, the popliteal vein. That's your 3-point ultrasound, all right? Okay, so again, just a reminder of the anatomy. Our 3 points are proximal, mid, and then popliteal. And what we want to do when you get to the popliteal fossa is see the popliteal vein, which is on top or superficial to the popliteal artery. We always say pop on top, but they're both popliteal, one's vein, one's artery. But the vein should be on top because it's superficial to the artery. And you kind of want to scan through it until it trifurcates to the anterior and posterior tibial veins and the perineal vein. So you kind of want to scan all the way down to the trifurcation. Once there's a clot in any of these smaller vessels in the trifurcation or below, it's so small that it doesn't mean it's going to propagate and become a problem or become a PE. All right, so once it gets lower than that, we're not really that concerned. It's only once it gets in that deep venous system. All right, so this is what we're looking at. So remember, playing my silly game about Mickey Mouse. So we get our frog leg patient, and the first thing we need to do is organ identification or anatomy identification, and we're gonna see this Mickey Mouse complex, okay? So here's a real live video. So depending on which side of the leg you're on, Mickey Mouse's ears are gonna be more to the left or right, okay? But anyway, what we're looking at is the saphenous vein spilling into the common femoral vein, and what you can't see here is you've got your common femoral artery, and they should be bifurcated. There's a superficial and a deep. I'm going to show you some more pictures. All right, just stay kind of. All right, so we're going to find our structures, apply pressure. You're going to visualize the artery. The artery doesn't compress. It looks like it's pulsating, and it's next to the vessel, but the vein itself will compress. And you can see what we're seeing here. This is the common femoral vein. This is the superficial and superficial and deep common femoral arteries, and you can see that the vein is compressing. What's this structure right here that has like a fat pad around it? What's that structure? Anyone? If you're in the femoral cavity or up in the inguinal area, what structures are there? Remember that acronym NAVEL? Nerve, artery, vein, empty space, ligament, NAVEL? Okay, so nerve, arteries, vein, okay, so that's a nerve. And that's important if you ever want to learn how to do nerve blocks. We actually will stick a needle in close to there, not into it, and we'll actually just squirt a bunch of lidocaine or marcaine and just kind of bathe that whole area. And it once it's surrounded with the anesthesia, that's how you get your femoral nerve block. So it's pretty cool, okay? All right, that's not the scope of this lecture though. Let me get back on task, okay? We're looking for DVT, and you're gonna be awesome. So this is that whole Mickey Mouse complex. Again, the greater saphenous vein is spilling into the common femoral vein, and we can identify the arteries which will not compress. So we usually do side-by-side pictures, and you guys don't have to do that for our test out, but in the ER, we'll do side-by-side dual imaging, where we'll freeze or show a little video of us not compressing, and then we'll show compression. So this is where that common femoral vein and the saphenous vein is all compressed, wall to wall, anterior, posterior wall, touching, no space in between. That way we can show there's absolutely no clot, okay? No clot in there, and so that's a good compression. Everybody agree? You can see no compression, and then once they push, this femoral vein and greater saphenous just completely collapsed, and you can't even see the structure there anymore. Everybody appreciate that? All right, good. All right, so this is an actual video of a positive DVT. As you can see, this is the common femoral vein, superficial and deep femoral arteries, and that saphenous where it's spilling into it did not compress. The whole thing did not compress. I'm going to play it again. The common femoral vein itself did not compress. Okay, they're pushing hard, and this takes some pressure. Sometimes I have to tell the patients, hey, this might be a little uncomfortable. Especially in larger patients, you have to compress more. And if it doesn't compress, that's a clot. You're done. It should compress. If there's a clot in there, there's so much back pressure, it doesn't collapse. So that's a positive DVT. All right, so that's our proximal picture. Now we're gonna go scan, so after we get the saphenous vein spilling into the common femoral, we're gonna go just a little bit distal, and we're gonna compress again, and it should compress. If it doesn't, it's a clot. All right, we're gonna keep going down the leg, okay? Now, we can see the bifurcation there. We're gonna compress again. Are we compressing okay? Everybody agree? All right. And then, so we did our 2 points, we did proximal mid, now we gotta get to the popliteal fossa. And once we get back there, again, the leg is still bent. You can still keep them in the frog leg position, and it's a lot more lateral than what you think. A lot of people will get right up in here medial, and it's actually a little more lateral in the leg, and you'll see pop on top, just 2 vessels, just like that, vein on top, and you compress, the vein will compress. And once you compress it, that's good. You should scan just kind of by tilting or fanning your probe all the way till you see the trifurcation of those 3 vessels and compress and make sure that you don't miss it. If you don't get that part for the test out, that's okay. A lot of our instructors are not like Captain Williams, who are ultrasound trained fellows. So if you at least get the pop on top and compress it, that's sufficient for your test out, all right? All right. This is where the trifurcates, your popliteal artery, the vein is compressed, and here's the 3 trifurcation of the anterior and posterior tibial vein and the peridial vein. If all those compress in that same complex, you're absolutely great. There's no way that there's a clot, a significant clot. So what does pathology look like? Well, we already know it's where it doesn't compress. But what else can it look like? Okay? Looks like there's something up in there. You guys appreciate that that's a clot? Sometimes these ultrasound machines that we have here are so good, you'll actually see the valves in the veins. So don't get confused, and once you see a valve, think that that's a little piece of clot. If it's compressing, then it's not a clot, but you'll actually see, just like we did with the cardiac exam, you can see some of the leaflets of the valves. You can actually see venous valves in some of these. And what's pretty cool and so funny, like slow Friday night party trick, if you just happen to have your own ultrasound and you're deployed and you're bored, if you're doing this view, if they valsalva, that common femoral vein will just like blow out real big, okay, because it's under pressure. So anyway, this is pathology. This is a clot floating around in there. And they're also trying to compress. You can see that the ultrasound machine looks like it's moving, or the probe, and they're actually compressing. Okay, here's another one. Non-compressibility, that's positive for clot. This is the right, this is the left superficial femoral vein. Both of them are not compressing all the way, and that's not lack of effort from the ultrasound person or the person doing the ultrasound. This is actual pathology. Just to remind you about, how we score DVT and stuff. Remember, I personally don't apply those criteria because if you have a gestalt or suspicion that there's a clot, it already warrants a test. And so you're going to do the D-dimer and the ultrasound anyhow. Yes, sir.
So it will not compress if there's a clot, but it will also not compress if that clot's more proximal and there's back pressure.
Allegedly. So like I said, when I yes, that's the point. There should be enough back pressure that it will not compress. That's why they only do 3 points.
Is there any validity to starting at the popliteal and just being like, all right, the popliteal, well, if the popliteal doesn't compress, then we know we've got
No,
something.
it's the opposite actually. If you miss that where it spills into the common the saphenous vein is spilling into the common femoral.
I got you.
Because that's a superficial system spilling into the deep. Theoretically, the popliteal could look normal, but there's a clot there. So you got to get that complex at a minimum, and you got to get the popliteal at a minimum. There are some studies out there that are saying you could do 2 point. You just do real proximal where the saphenous is filling in and popliteal. I get your logic. Yeah, but because it's going superficial to deep, you have to get both. Again, I was taught we scanned every couple centimeters, and that's just because back then we weren't really sure that there'd be enough back pressure. Do you have a comment on that?
I'm just moving. Okay, yeah, okay, so
He's pacing around, so I feel like he wants to do something. He wants to say something.
pretest probability of the clot is really important, which is why Dr. Anderson was saying not using the Wells criteria, because if you're concerned there's a clot, then the Wells criteria is inherently not applicable to the
It's already positive.
risk.
Yeah.
But with the ultrasound, I got into this a lot. The argument between the full leg and the 3 point is they're both roughly 94 to 96% sensitive and specific for for finding those DVTs compared to a whole leg, including the lower part, right? So the 2 point is in the 80s. So if you're okay with almost 20% of the people with DVTs going home and potentially getting a PE and dying, that's okay. I'm okay with the 94, 96% because they're equal to the two that we do. So 3 point is good. The whole leg is obviously better if you go every 2 centimeters and push your way down, but that takes up a lot of time. 3 point is you got to think where the blood flow is coming together, converging, is where there's going to be the eddy effect or like the movement, and that's going to cause coagulation.
Okay. So we talked about our differential with DVTs to mimics, right? So the first thing is we think about cellulitis. That's the one I see most common, is we'll see a cellulitis. So you see a red hot swollen leg, you're like, I don't know, that looks like infection. But people have venous stasis. They have all kinds of things. They have chronic tidal edema. I've seen CHF so bad that the legs are just leaping fluid literally outside of the leg. It's disgusting. And so a lot of times, you know, red hot swollen leg, it could be cellulitis, it could be erysipelas, you know, which is a cellulitis. And this is what they typically present with, especially in the lower extremity, below the knee. This is what it looks like. And of course, we learned about cerulidolens and albidolens and last block. That's the extreme form of a large DVT in the femoral vein, while proximal causing arterial spasm. But most of the time, they present like this. And your guess is as good as mine. If they say, yeah, I've had a fever and some chills, and I had a bug bite, now it looks like this, it kind of points you towards the direction of cellulitis. But the good news is, the ultrasound machine at the bedside, you can still definitively say there's nothing proximal. You do a quick DVT ultrasound, even if you're compressing every couple centimeters, it only adds like 10 seconds or 15 seconds to your exam. It's very quick. And then superficially, if you wanted to go down to where it's red and hot and swollen, you can actually see cobblestoning and evidence of cellulitis. And usually I put that in my lecture, but I was trying to keep it short. So we'll learn about when we do soft tissue and small parts and MSK. I'll show you the difference between cobblestoning with cellulitis versus fluid collection with abscess, things like that. But the good news is that at the bedside, you can make a real-time decision. And this matters. If you're in a pre-hospital environment and they have a red hot swollen leg that looks like this, you're like, do I need to evacuate this person? Or are they just, I'm just giving them some sort of like Bactrim, Doxy, Keflex kind of situation, right? That matters. So anyway, pearls, remember we were trying to compress. Arteries don't compress, veins do. You have to get that proximal complex of the saphenous veins filling into the common femoral. So it should look like Mickey Mouse with their little ears and like an exclamation mark, and the exclamation mark and the entire face of Mickey should compress. You have to do that first, then you go distal where you only see really just two structures, the common femoral artery, common femoral vein. You're compressing the vein, that's your mid. And then your popliteal fossa, pop on top, compress that. And if you're really good, you'll fan through the trifurcation on the popliteal area. Any questions? So what we're gonna do now is just a quick like 5-minute break, and I'm going to take this thing off, hook up my HDMI, and we're gonna demonstrate both exams for the entire class once, and then that way you guys can break off. And then the ultrasound machines are available at lunch. I'm here all day if you guys wanna come in, or if you wanna stay late or get some more reps. I appreciate that there's a lot of you and on so few machines. Are there any questions about anything we covered today? So now you've got the EFAST and the 2 other testable exams. Your instructor will decide, or you, depending on your instructor, if you're doing the DVT or ocular as your other alternative test out. Everybody does EFAST, and then you'll get one of these others. A lot of instructors let you pick. Some people don't. Dr. Love has a little cup that has something pre-written, and you just your fate is whatever you pick, okay? It has to be different, right? She confuses you, and then she'll hand you a piece of candy on the way out, and you're like, I don't know what happened to me, like, she hurt me, but then she gave me candy. It's just a very emotionally, confusing situation. But anyway,